While managed care was officially born with the Health Maintenance Organization Act of 1973 under President Richard Nixon, it's gone through numerous adjustments in the decades since, primarily oriented towards managing cost. And today we're in the midst of another sea change in healthcare reimbursement, from volume to value, which demands its own brand of managed care contracting. Hi, I'm Amy Grant of the Adaptive Business Leaders Organization, and fortunately last month in our ABL San Francisco Roundtable, we had the opportunity to mentally sit at the feet of one of the nation's foremost experts in value-based managed care contracting, Stephen L. Goff. Steve Goff is a leading healthcare partner in the Sacramento office of King Spalding with deep expertise in all aspects of contract negotiation, which he's been doing for the past 35 years. More recently, in the past 5 years, Steve has been the lead negotiator for CalPERS, the California Public Employees Retirement System, in its high-profile contract negotiations with major health plans. To put it in perspective, CalPERS administers benefits for over 1.5 million members and their families in the program, making it the largest defined benefit public pension plan in the country. And in 2017, they spent $8.88 billion to purchase those benefits. Steve has also represented Sutter Health in its development and contracting under the capitated and delegated model for over 27 years and helped them align their internal systems and incentives with their contracted health plan incentives. Little wonder he's been recognized in the best lawyers in America every year since 2001 for healthcare law. So here are a few of the highlights from the 3-hour-long presentation discussion that Steve shared with us. First, what is value-based contracting?
So let me start by saying what I mean by transformative. Transformative means, in my lingo, that it's sort of so different from the basic fee-for-service model that it actually changes people's behavior in the system, in the healthcare system. That doctors begin to actually go, could I discharge this patient today? Let's run a panel and see if maybe I can. So when I say transformative, I'm sort of talking about how much money is at stake, how much money is at risk, what is the proportion of the money you're going to get to the money that you're guaranteed.
How far along are we in this transition to transformative change?
In California, I think that we're about midway through the arc of some real transformative change. We're certainly not all the way there, but we've come a long way. This is my own belief in seeing, working with both the medical groups, working with some health systems in California, and then seeing it from the top down at CalPERS, and within, depending on IT changes, which drive a lot of this. Within 5 years, we could see real changes in the ability to monitor some of the performance metrics that I've talked about earlier today, which I consider to be big Q quality of care as opposed to just outcomes. I think in the rest of the country, we're in a very different place. I mean, in the rest of the country, except for some large urban centers, we're way behind. There's just been a real unwillingness to get away from the fee-for-service model and really embrace the kinds of things we've been talking about here today. I think that part of the trajectory, the IT systems and the people to utilize them, is a factor that we're going to have to take into account. But as I say, in California, I think we're 50% of the way there on the arc. In other places, I would say not even to a quarter. So we've got a long way to go.
What are the most common forms of value-based contracting?
Sort of value-based managed care contracting, what a lot of us sort of generally think about is we think about it as contracts with healthcare providers that compensate those providers in whole or in part based on efficient care management, meeting or beating a global cost of care budget, and meeting performance and quality criteria. And usually all three of them find their way into a value-based contract. But efficient care management and meeting or beating a global cost of care budget are pretty similar. I only separated them because in the global in the capitation model, it's really efficient care management. And then the global cost of care budget is really a separate thing called the shared risk arrangement. And so I separated those two. But really, in reality, those two work hand in hand together. Most of the contracts that I work on, most of the hard work is done not in the defining efficient care management, because frankly what you're doing is you're agreeing to a capitated amount, and it's up to the provider to make that work. So when I'm doing it from the provider side, we are thinking about our care management systems, our referral systems, and trying to make sure that we can do things in an efficient way, and trying to overcome inefficiencies, which is extraordinarily difficult. But meeting or beating a global cost of care budget, that's the more sort of predominant thing you see around the country.
Are there other examples of value-based provider payment methods?
Capitation, premium sharing arrangements, I've talked about those. The shared risk upside and downside, I've talked about that. And I mean, even bundled fee-for-service payments can be, even though they're fee-for-service payments, because they're bundled and there are a number of different providers who are involved in receiving payment out of that bundle, there can be some element of value-based involved in that. On the next page, value-based light, even the DRG system to some degree. If you can efficiently move patients through your hospital, you will be compensated better to average total cost by Medicare. So there is some value-based components in other types of payment methodologies. What I would consider to be sort of the quintessential not value-based is just percentage charges reimbursement, where I don't see much value-based there.
What resources does it take to be successful with value-based care?
To really do this right, it requires significant investment. You have to have people, I think, with experience in the healthcare field who have been around it for a long time, who know how to look at healthcare delivery systems and see what areas create the eddies that create inefficiencies, what areas are ripe for sort of improvement with the use of good metrics. All of that takes expertise, thought. It's not something to be done lightly, but I think that it's definitely the way to go for the future.
And how does value-based play out in other areas of healthcare?
So I think it's coming for every part of the space. We actually do have home health, nursing home entities that are coming to us and talking about whether there's a way that they can be involved in a capitated model and how that capitated model will work. There's already a lot of value-based built into the new home health compensation model that's no longer based just on the clinical interventions. So it's coming in those areas as well. I'm feeling it.
And last, how does value-based managed care contracting impact market share?
And I love fielding those questions from those providers that are starting to say, looking ahead, I'm going to need to do this. And maybe I'll finish off by saying this. Why? If you're getting fee-for-service, why are you doing it? And what they're talking about is they're saying market share. I need to lock down my market share. And capitation helps me lock down my market share because I have an assigned number of patients that are mine that I have to deal with. And yes, there's responsibility to deal with that within a budget. But the fact is, I got those patients, and that's my market share, and that's my business, and I can scale my business to the number of patients I get assigned.
So there you have it. Words of wisdom from Steve Goff, truly one of the nation's most respected authorities in the area of value-based managed care contracting. Words that are worth listening to twice and sharing with any team members who are still yearning for fee-for-service. Because clearly, especially in California, that train is pulling out of the station.